If someone's talking about taking their own lives, always take that very, very seriously. Most of the patients I see have significant history. The chances of overdose are sky high. Very hard to care for anyone else if you're not taking care of yourself first.
Hello, everyone, and welcome back to Compassiviste Dialogues with another episode. And today we have Dr. Theodore Bender. A little bit about Dr. Bender before I have him speak. Dr. Bender's been to school at Harvard, Brown University, Texas A&M, and he is a clinical psychologist. Dr. Bender's worked with the National Alliance on Mental Illness, and he's also worked with the Ministry of Defense, the Department of Defense in the United States, on military suicide prevention and mental health. And right now he is the CEO of Gatehouse, which I will let Dr. Bender come in and explain to us what he does there and what his role is before we get into the questions. Hello, Dr. Bender.
Thank you for having me. Gatehouse Treatment is an exceptional treatment facility in Nashua, New Hampshire. We also have another entity here called the Mat Care Clinics, where we provide psychiatric medications to fight opioid use disorder and overall mental health. And we really specialize in helping people who are really at their wits' end. They're struggling, they're on the streets, homeless, and we have an exceptional ability of getting people into treatment, removing barriers to get them into treatment, and getting the help that they need rapidly, which, as you know, at this point in the evolution of the opioid overdose epidemic, is key to saving lives.
Yes, and we will get to that. Let me ask you a little bit of background first. So, what made you get into this field?
Yeah, that's another great question. I was doing my residency at Brown University in Rhode Island, and I had the pleasure of beginning to work with some veterans of the Iraq and Afghanistan conflicts, some of them coming back literally from being in theater. And I just started to notice this pattern where I was treating the post-traumatic stress disorder, but every one of them had a co-occurring substance use disorder to deal with the symptoms they were experiencing from PTSD. And if you're familiar with post-traumatic stress disorder, the symptoms can be brutal, and sometimes people find ways to self-medicate. So I was dealing with the PTSD and then quickly seeing that the opioid use disorder might be the more dangerous and immediate threat. So I had to switch gears quite often to dealing with that because the risk of overdose was so high. And that was 11 years ago, and the threat is much worse now. But I eventually started becoming interested in addiction because of my work and experience working with veterans. And that led me down the path of specializing in addiction. I've been focused on that field ever since.
And speaking of addiction, because when you come from learning with veterans, I mean, there's a contextual attachment there that, they've been through conflicts and situations that may cause traumatic, senses for them to become addicted to something later on. But sometimes it's not necessary that somebody has gone through trauma to become addicted to drugs. Can you give us a brief background from your scientific perspective as to, is there any science behind guaranteeing that a person can become addicted or not?
Yeah, there's a lot of science in the addiction field. And kind of what you're speaking to is the nature-nurture aspect of it. So if you have a strong family history of addiction, and maybe you don't experience any significant trauma, you still have a pretty decent chance of suffering from some sort of use disorder as you grow. It's not guaranteed. The environment's actually the most important piece. So if you're raised in a loving, supportive family, you got better odds. But the genetic link is very real. In my experience, and the patients that I work with typically, the vast majority of them do have significant trauma experiences in their lives, whether that's in childhood and adulthood or both. It could be one very significant stressor or many, many over time, but just kind of anecdotally on the ground, most of the patients I see have significant trauma history.
So it's kind of safe to say preventing the trauma prevents the addiction in a sense.
It certainly can, yeah.
And so somebody seeking treatment to get their life back in order, well, naturally, first is the preventative measure of not getting into this mess in the first place. But when they are in this position, where do you tell them to start?
Yeah, that's a great question. When someone is just first seeking treatment, a lot of times they need what's called detox level of care. And really that all that is stabilizing them medically. And that's where you got to start. Once they've gotten some stabilization, maybe 30 days or so of sobriety, and they're on the right medication, that's when you can kind of start working on the trauma history. But even then, it is very early to get into deep trauma work. You still got to focus on maintaining sobriety, still very early in the sobriety journey. But you can start teaching some skills on how to deal with anxiety that's directly related to trauma. And PTSD is an anxiety disorder. So you can start teaching them skills to deal with that anxiety that comes along. And after some more time and some continued sobriety, my recommendation always is, after treatment or, getting started during treatment, is to work with a trauma therapist long-term to resolve some of those issues.
Basically, when you talk about rehabilitation, you're talking about a stage when somebody has already admitted to having a problem and wanting to find help or to secure help in some sense, a medical help. But in the opening sentences of this conversation, you said that the drug epidemic is getting much worse now than 11 years ago when you were involved with it when you first started. And I'm seeing this with fentanyl in the U.S. There are, drastic stories of the effects of fentanyl in the U.S. and not necessarily by people who are addicted to it and know about it, but even by people who have absolutely no clue that they became addicted to fentanyl or they just used fentanyl. So my first question there would be, where does a person start to find a way back to rehab? I mean, from that stage of being fully addicted and unaware to be able to shift to a space where I need help?
Yeah, that's a highly individualized question. You hear the term rock bottom a lot. I had to hit rock bottom.
Yes.
I've never really liked that term because you can always keep digging. There is no bottom. You can just keep going lower and lower. But there is a point where at least people start to think about, maybe I need to make a change. Now, it could be years from that first thought before they actually enter treatment. Another misnomer or myth that I hear a lot is that at any given point in the United States, 30 million people have a substance use disorder. But at any real given point, only 10% or less are actually seeking treatment actively for that substance use disorder. So whatever brings them to that point is kind of when they start to think about it and then maybe actually take action. It's different for everybody. Some people realize they have a problem very quickly and get into treatment and nip it in the bud. Other people, they have to go through tremendous pain and suffering and loss before they're willing to go to treatment.
So basically, it's just the person's character or the person's awareness of their situation that leads them to seek help. There isn't a trigger that can have them seek help.
There can always be some trigger for them. What it is for that specific individual can vary greatly in.
Okay. And now, speaking of the fentanyl issue, can you please explain fentanyl briefly? Because a lot of people think of fentanyl like, here's marijuana, here's cocaine, here's fentanyl. And I think fentanyl is becoming a very, very dangerous issue. And a lot of people don't understand how dangerous. So can you give us a little bit of feedback of that?
Yes. The biggest difference, like I was talking about, like 10, 11, 15 years ago, it used to be heroin was the big risk. Fentanyl's way worse. It's way more deadly, and the chances of dying from it are way higher. That's why we've seen such a dramatic increase in opioid overdose deaths over the last 10 years. In fact, in the last 12 months in the United States, there have been over 100,000 overdose deaths. And many of these deaths, 80,000 of them, if I recall correctly, fentanyl, the synthetic opioid, was involved.
Wow. I didn't know it was 100,000 over the year. That's a ridiculous amount.
I was watching college football a weekend or two ago, and I was watching the Michigan game, and their stadium holds, I think, 100,000 or 110,000 people. And the first thought I had when I saw the entire stadium filled was, that's how many people died in the last 12 months. And just for a minute, it just blew my mind when I saw the actual visual of what that actually looks like. It's happening every single year.
It's really something to be able to see it visually, like you said, and imagine that is the amount of people right there. It's crazy. And the problem with fentanyl is I'm hearing a lot of stories out of universities, out of other places that you otherwise don't really associate with drug overdoses and deaths, of people using something that is as they say, laced with fentanyl or whatnot, and they're dying from it, or they're having severe health problems because of it. And is fentanyl something that people are seeking, or is it something that is kind of being imposed on the community, as opposed to cocaine is a drug that people may seek out for the effects that they assume that it will bring to them?
That's a very good question. And over time, what I have seen, and national statistics show, heroin use is actually declining. Fentanyl use is exploding. And most of my patients that have opioid use disorder that I've seen in clinics and places I've worked across the country, their primary drug of choice is now fentanyl.
Wow. With all the awareness and all the science and all the knowledge, it's not slowing it down.
No. We're at 100 to 110,000 overdose deaths. But imagine how high it would be if we didn't have all the good people, men and women across the country fighting this disease, and the evolution of Narcan, which is the opioid overdose antidote. It would be, half to 150 to 100% higher, I'm sure, if we didn't have these preventative measures.
And that's something that, on the one hand, great for science, but on the other hand, it worries me, because if it was not for the tech that we have, the numbers would be really devastating. So The tech is really fighting the fight for us here, so to speak, and all the people like yourself who are dedicating all this time to trying to figure out and sort out the issues. And speaking of that, based on your experience with vets, which made you really switch into this field, as you said, and all of the experience you have, PTSD, and like you said, as part of an anxiety disorder, seems to be the driving factor in a lot of these addictions and situations. So, Dr. Bender, say I have a family member who has an addiction problem, and they are unwilling to acknowledge that they do, and they're in denial, which is something that you hear often from the psychology, people being in denial. What are the steps to helping family members, friends, anybody, to kind of get them from that couch with alcohol or with drugs in their hand to your couch so you can help them?
That's an excellent question. And this is what I always tell family members. You can go the route of an intervention. Many people have seen that TV show, Intervention, and how they do it. And you can get the whole family together. And I always recommend hiring like a professional to help with that if it gets to that point. But my main concern in those situations, and family members and spouses and parents are often find this kind of surprising, my advice to them always is to take care of themselves. And if that involves seeking professional help through therapy in order to help set boundaries, then you got to take care of you first. Self-care is the most important piece. It's very hard to care for anyone else if you're not taking care of yourself first. That's always my primary recommendation. And then it comes to boundaries. If someone's living in your house, son, daughter, spouse, whoever, and they're just wreaking havoc and destroying the family system with their use disorder, you have to make a decision. What are you willing to do? What are you willing to say? What kind of boundaries are you willing to set? If in fact they decide not to seek treatment, because that is their ultimate choice. They don't have to go to treatment, it's their choice. But you also have choices too. And setting boundaries and being firm about what you will and will no longer tolerate is really my primary objective when I move in.
Okay. So me first, and then try to help the person within reason that they're willing and able to be helped to come to you, for example.
Yeah.
Okay, fair
I think
enough.
a lot of people are surprised by it. So people are surprised by that approach quite a bit, but that's really an angle I always take.
Yes, it is surprising, but I can also see the benefit, because you're right. A lot of families break down and shatter because of the one person in the family who's unwilling to change or seek help. And you're looking out for the whole family as opposed to the one person. Right. And now you've dealt a lot with vets, and taking this previous question that you just answered to with your different approach, how have you seen anxiety and PTSD affect the veterans, and how do you form a solution for them to seek help?
Yeah, another great question. A lot of our homeless veteran population that suffer from substance use disorders, a very high percentage of them have post-traumatic stress disorder. And PTSD, despite how difficult it is for people to deal with and live with, it's treatable. It's a treatable condition, and there are very good treatments out there. Of course, you need to specialize in these kind of treatments. You need to know what you're doing. And you have to focus on the substance use disorder as well, because that's the most likely, or the most dangerous piece of the package. But treatments like cognitive processing therapy and exposure-based therapies for PTSD are very effective. It's not the easiest work for the patient or the therapist, because the therapist is actually getting exposed to quite a bit of the trauma that the patient has gone through. But with highly qualified professionals who specialize in this, I've seen veterans make incredible turnarounds in their life. The memories of war will never leave you, but the way that you react to those memories and the emotional responses to those memories can't change.
Okay. And so, speaking of mental health issues, another statistic that I see in the US quite often that is shocking is the depression and suicide rate. And I say this from a global perspective of many countries around the world think the United States is this, green grass essentially, and the land of opportunities and all the wonderful things that comes with the US. But then there is also this side of serious suicide numbers and depression. Can you shed a little light for a global audience of why this happens in the United States before we get into the science of the mental health?
I spent years as a suicide researcher. And since the time I started doing suicide research, the number of suicides per year, I think, has gone up 10 to 20,000. I think the last statistic I saw was around 50,000 annual suicide deaths. A vast majority of those suicide deaths are handgun related, just because the lethality of it. People who try to die by suicide using other methods like overdose or cutting their wrist, they have a higher survivability rate, but there is a very low survivability rate when it comes to handguns. And we all know that, as far as countries that have the most handguns, we're not first. We're probably pretty close up to that. So there is incredible ease of access to firearms, which contributes a lot to it. But the next question is, why is it continuing to rise so fast? What is going on in this country that is contributing to that? And like you mentioned, increased rates of depression. In completed suicides, the vast majority of people that die by suicide also have a major depressive disorder or some history with major depression. So the two kind of go hand in hand.
And if you were to discuss suicide and kind of give us a preventative approach from your research over the years, what would you say would be the first few ideas that you would throw out there to say, this is how we can reduce those numbers? This is how we can turn this around. What would be your advice?
First of all, I would think about stigma. People who suffer from suicidal ideation or suicidal thoughts often feel like reaching out for help is a sign of weakness, and they won't do it or won't say anything. A lot of people that die by suicide didn't really give a lot of signs to people around them. And people are often very shocked and angry with themselves that they didn't see the signs, but there may be very few. A suicide note is left in less than half of all completed suicides. It's kind of a myth that everybody writes a note. So reaching out for help, for people who are feeling or thinking about harming themselves, reach out early. And for people who are loved ones or friends or acquaintances with someone who may be suffering, don't be afraid to ask them about it. A lot of people fear that if I ask you, hey, are you feeling suicidal? Or are you having thoughts of hurting yourself? You're going to make them more suicidal. But there's an overwhelming amount of research that suggests quite the opposite fact. That not only does it not make them more suicidal, it may actually reduce suicidality because somebody cares. So there's those pieces of it. We also need to get better at detecting suicidality. One example that we used to run into with the military, and we did a lot of studies on this, is that if you're coming back from Iraq, Afghanistan, and you're coming back to the United States, you want to go home. You want to see your family. If you run into someone like me or like a military psychologist or psychiatrist or someone in the mental health field, and they start asking you questions about suicidality, they're smart enough to know that if they start saying yes, they may be triaged. They may not get to go home right away. So a lot of them will hide the symptoms in order to avoid any kind of further treatment or hospitalization or whatever the case may be.
Okay. And so the next question that relates to this would be for me, when we discuss suicide, and that was the first response you had was to talk about it. And I think a part of it is also the fact that the people who you would reach out to speak with may not take you seriously, and they might not give it that importance or value that it should. I may say, I'm going to kill myself. And people will be like, go ahead, jump off the ledge, or they may make a joke about it. And so that really affects the case. And I think, am I right to say that we need to open up on mental health issues and how serious they are and reduce the jokingness around it and the comedic aspect of it, and to make it lighthearted in a sense, and to reduce that? We think we're reducing the stress and the trauma by joking about it, but in fact, we may be doing the opposite.
Yeah, I would suggest for anyone who's listening, if someone's talking about taking their own lives or having thoughts of suicide or self-harm, no matter what or how often they're saying, always take that very, very seriously. If they're having these kind of thoughts and they're verbalizing these thoughts, and especially if you start hearing things like a plan for suicide, I have a gun, I'm going to go use it on Wednesday when nobody's home. That's imminent risk. That is time to get professionals involved at that point. So yes, early and often, and always take it seriously.
That was really good, because you are right. Sometimes it would just be a sentence that's not repeated often, but sometimes it would be very detailed. And that's a time when people should take it extremely seriously. Now, I want to take you back to fentanyl, and I want to talk about fentanyl and how it's affecting the population that do not know that they've just consumed fentanyl, that they've just taken fentanyl. What should we be looking out for? I mean, myself, I come to New York, I come to LA, and I may go out and have a drink or something. And, I may not know. What am I looking for in terms of symptoms? What am I looking for in terms of, preventative measures? What are your advices on this, since you've been dealing with this forever?
Yeah, that's a good question. First things first, the most dangerous way to accidentally or unknowingly ingest fentanyl is street-pressed pills. So you think you're just getting some prescription that somebody's selling to you. They're not prescription meds, they're pressed on the street. They may look exactly like what you'd get from a CVS. And what we're also seeing, rises in adolescent overdose death. Back when I was a kid, experimenting, if you will, was maybe a little bit of liquor from your parents' liquor cabinet, or maybe a little bit of marijuana. These days, kids are experimenting with stuff they find in the medicine cabinet, or pills that they're getting from their friends or whoever. And they have no tolerance built up for opioids. If you take a street-laced pill with fentanyl in it and you're like a 15-year-old kid who's never used opioids before, the chances of overdose are sky high. But it doesn't stop there, because we're seeing overdose deaths in other drugs rising also that we didn't normally see in the past, like methamphetamine and cocaine. And we're finding that a lot of these deaths in the toxicology report are showing fentanyl. It gets even worse, as if it couldn't be worse. There's a new drug now you may have heard of called xylazine. Mm-hmm. Xylazine it's a non-opioid sedative that's getting mixed with fentanyl. And what's worse about that is that it's resistant to Narcan, the opioid overdose antidote. So while Narcan was saving people from overdose deaths, people that have ingested xylazine along with the fentanyl, it's called Trink, by the way, the two drugs combined, we're seeing that Narcan isn't working. I think you asked about signs and symptoms.
And basically, the Narcan is falling behind the drug instead of being ahead of it.
Yeah, something you asked about signs and symptoms of possible overdose. You may notice if someone who is breathing very shallowly, maybe like less than 12 breaths per minute, their lips may be turning kind of a blue tinge color. You have a very raspy sound. It's called a death rattle, where it's a very raspy sounding breath or breathing. And typically what you would do in a scenario like that is you would, shake the person a little bit and say, hey, are you okay? Are you okay? If there's no response, the next step is to take your knuckles and kind of drag them across the sternum. And a lot of times that will, wake people up if they're not overdosing. If there's no response there's a very good chance that person is ODing. And
that's the 911 time.
It's 911 and Narcan. I personally carry Narcan with me everywhere I go, and it's readily available now. It used to be hard to get. You used to need a prescription. You could get it anywhere. I carry it with me at all times. And a lot of times, if administered quickly enough, the Narcan will reverse the opioid overdose, bring them back to life, so to speak, but it's still hospital time at that point. It's not, okay, get up and go about your day. You still need to go to the hospital. And it's also, I mean, if you're not in treatment at that point, thank your lucky stars that you made it through that and get yourself some help.
And before I let you go, a question. There was recently a mass shooting in Las Vegas, and you've spoken about the violence and the psychological effects and issues around that. Can you explain to people what triggers these mass shootings for the most part?
This is a topic that I'm pretty fascinated with as well from a mental health angle. And I don't know if there is a single kind of consistency from shooter to shooter. A lot of times we never know, right? Because oftentimes they either die by suicide or they die during the police engagement. And not every one of them leaves a manifesto or writings behind as to why they did it. I'm sure that, severe and intense anger is involved in a lot of cases. They may feel wronged by society or by certain people or by a job that fired them. But I'm not sure we fully understand just yet as to why this is happening so much and so often. It certainly has to do somewhat, at least, with the easy availability of firearms in the United States and how many guns we have per capita in the United States. But that's not the whole thing. This didn't used to happen all the time, to the point now where we're so sensitized to it. It's almost just like, oh, there was another mass shooting, and that's a horrible way to think about it.
Right. I mean, there was one the day before as well.
I know. And it's just so, whereas it would eat up the news cycle for weeks when they first started happening. You remember back to Columbine, which a lot of us consider the beginning of all. Now it's just like it's in and out a day or two. It's past the news cycle, and we move on, and nothing really changes.
Right, and like you said, from a historical perspective, it's not like guns were not part of the American social being, but it's just triggered something recently that it's exploded so much. I mean, there's been 500? I read 560 mass shootings this year, and the year hasn't ended yet. Hopefully, there's no more. But I mean, that's a ridiculous number, right? You just can't even think about more than one a day. Is that thought? What do you think could be, aside from the guns and the availability and the lax restrictions to be able to get one? What would you assign to be one of the more severe reasons as to why somebody, even if you're fired from work or even if you're having a bad day or whatever, what would trigger you to get up and go do something like this? I mean, there has to be a psychological backstory to this to make sense of it, because everybody's trying to make sense of it.
Yeah, and I don't think anyone's really gotten to the point of full understanding yet. Lots of things cross my mind, and it could be different for different shooters, but certainly I think intense and severe anger as society or specific groups, we've seen that. The hate crime versions where, a black church gets shot up and it was, very racially motivated. So hatred and anger. We also have to consider sociopathy and psychopathy in people who are doing it because they're psychopathic or sociopathic murderers. But then there's also the severe mental illness component that happens in some, but maybe not all. And then just the overall access and ability to be able to carry out these events. There are other countries across America I couldn't quote, or across the world I couldn't quote which for you, that have very few, if ever, any gun deaths, right?
Yes.
And they're probably looking at us like, what is going on over there in the West? So I think it's, I don't think that we really have all the answers yet or really know why. And more importantly, I think it's at the point now where we pretty much don't know how to stop it. And it's gotten to the point where almost everything we even try to do fails.
Right. And that was basically my question. I mean, it was essentially everything seems to not help. And, you get to a point where you think, do we just deal with the statistics and say we're looking at about an average of 500 mass shootings a year, and this is just how it's going to be, so schools are unsafe and everything's unsafe? Or do you think that we will eventually, through science, because I really believe in science and tech in the sense of it's responded to a lot of our issues. I mean, we just went through a pandemic that was not as dangerous because of science and tech than it would have been, than it was actually 100 years ago or 200 or 500 years ago. Gradually each pandemic is becoming less severe in its detrimental outcome. So do you think that there is a psychological understanding of this that is, waiting to be unlocked? Or do you just think it's part of the social fabric of the American life, being that it is an American problem, essentially?
That's a good question. The social fabric part is interesting what you just said. I do know that there are researchers and people dedicated to this at universities across the country and across the world, very brilliant people who are studying this and trying to figure out ways to reduce the gun violence in America. And yes, I hold out hope that we'll figure something out. Generally, what I see in the news and with the government is like the main drivers to try to reduce or ban assault rifles. And it'd be interesting, and I don't know the statistics on this, it would be interesting to see, it's probably lower, it may not just be for this reason, but like there was an assault rifle ban in this country at one point. I can't remember whether it was in the 90s or whatever. And I'm pretty sure that shooting deaths were probably a lot lower during that time, although I have to check. And that might not be the only reason. Like you mentioned, the social fabric of the nation may have changed dramatically. And certainly the advent or the invention of the internet and just how much knowledge we have access to. And if you've noticed, and you think about the internet a lot, is people now discover very easily when other people have different opinions than they do, and they become outraged with that very easily. So I wonder if how much all of that kind of interplays and has kind of got us to this point.
But I also agree with you in that, reducing the possibility of having the assault rifles and the guns plays a significant role. I mean, it's somebody once told me this. They said, reduce the speed limit to 5 miles an hour, and you're barely going to have a pedestrian death or a major accident with, traumatic outpouring from it. So, it does reflect an amount, but it's not going to, it may minimize it, but it's not going to delete it. So this may be an analogy to use with the gun violence situation. Take away the guns and the chances of somebody trying to, stab 40 people at one shooting is going to significantly drop, right? So I hope that the science responds to it as well. And finally, I want to ask you about your charitable side, being that everything that you do and a lot of the work that you've done in the past as well has been with charities and supporting charities. And tell me why you believe supporting charities is important, first of all. And second of all, who do you support?
I think in my own personal life, my favorite charity kind of has nothing to do with addiction, really. It's on mental health. It's St. Jude's Hospital. I mean, I just love what St. Jude's does. I often imagine myself in my older years when I kind of retire from this business, kind of just working for them in any capacity that I can, because I just absolutely love that organization. In my work life, when I think about charity work, what we do here at Gatehouse and a lot of other facilities that I've worked at, we always try to have at least one kind of scholarship case, so to speak, and we're always very open to that. In fact, I offered a scholarship case to someone the city's been working with just yesterday. Well, we always try to have at least one or two people in our program that don't have any means, they don't have any money, they don't have any insurance coverage, and we kind of just take them anyway. So I always feel really good about that. I wish half my population could be in that scenario. But I've been doing that throughout my entire career, and every facility I've ever worked at, we've always had just scholarship patients, charity cases to try to do, offer exceptional treatment regardless of ability to pay.
Perfect. That is the ideal of medicine, right? I mean, you're treating people, not money. That's what I always say. And now, before I let you go, St. Jude's, for people globally who may not know what it is, explain to me what you love about them and what they do so people can also support them.
St. Jude's is a children's cancer hospital. And quite simply, they treat children with cancer. They charge you nothing, $0. And they even provide somewhere for family members to stay while they're in treatment. I mean, how much more just kind of heartwarming message and organization can you possibly be than that? I just absolutely love what their mission and what they do and what the services they provide and the lives they save.
And hearing you speak so highly of them and not being affiliated with them and not working for them. And this isn't a marketing pitch for them. It's just your personal opinion that they do great and you love being a part of supporting the great work they do. And I hope a lot of the viewers who want to help children with cancer to be able to look up St. Jude's as well. I want to thank you for your time. And this was a great conversation. And you've really shed some light on the immediate ways to fight addiction and some of the mental health issues, and to open up and to take things seriously and to listen to people and to try to get them to a professional like yourself. The sooner the better.
Thanks for having me on, Ellie. It was great talking to you.
Thank you. And this was another episode of Compassiviste Dialogues. I hope you've enjoyed it, and donate to St. Jude's.